Thank you, Nalini, and thanks, John Mark, for the introductory slides. This is the team that is working with us in Pakistan. Adnan Haider is a colleague of mine at School of Public Health, and Uzma and Nadeem, who are my colleagues from Pakistan, who are working this, on the project. So I'll start with the history a little bit. 2002, 2003, I had finished my residency a couple of years ago. And I was working at Emory. Art Kellerman was chair. He got invited at Fogarty to talk about potentially investing in emergency care, trauma, injuries. And he said, do you want to go? And I said, wow, this is great. NIH, I've never been there. This sounds great. I was there 2002, and we talked about how Fogarty should invest in trauma research, and what should that investment look like. So as somebody who was really starting my career, it was a great opportunity to learn about how Fogarty and I thinks about these things. A year later, so I was at Emory, we saw the announcement, we saw writing the grant. A year later, I ended up going back to Karachi and got the grant on the other side as a low middle income country collaborator. And then in last year, a couple of years ago, back in the US, and then applied the grant from this end. So had a really interesting experience of being in the room when it was first thought about, then running it on the other side, and then coming back and continuing that in the third cycle. So I'll start with, and most of you are aware of the disparities in research resources. US, you see the life expectancy differences, 81 versus a country like Pakistan, 66 years life expectancy. If you look at the publications, for example, per 100,000 population, you can see the difference, huge difference in terms of research output and the amount of money countries spent on research. And that is despite the fact that if you actually look at the disparities in the burden of disease, and I want you to focus on this middle column where there are emergency diseases, the disability-adjusted life years lost due to emergency diseases. Globally, 138 years of life lost per 1,000 people per year. In high-income countries, that number is 63, and in low-income countries, it's 279. So emergency diseases, so the mortality rate is about the same, but the burden of disease, primarily because of disease such as trauma, cardiac arrest, stroke, is multiple times higher in low and middle income countries. Also, if you look at research, now that we saw that the burden of disease is very high, if you look at the research coming out of LMICs, and we looked at the 5 top journals in emergency medicine, 96, 97% of publications are obviously from high-income countries. Also, we looked at the Fogarty grants, NIH grants, in emergency medicine and LMICs in the past 10 years. There were 17 grants, out of which 5 were to Hopkins and 3 to Forward Program. There was only one R01, one R21 and 12 D43 grants, which is more training grants, and that's what we're talking about today. So while the problem is pretty big, the local resources are lower, and the investment in terms of funding as well as publications is relatively small. We also looked at the type of trauma research that's coming out of these countries. And again, about 5-year period, 407 publications, total of which only 7 were cohort studies, 1 was meta-analysis, 1 was RCT. So we have a issue of investment, we have issue of publications, the research output in the context of very high burden. So that is the introduction to what we are doing in Pakistan. And very quickly, this was these were our objectives for the second cycle. we wanted to develop a core group of researchers. We initially, for those of you who are aware of, know Karachi and Pakistan, we were in south of Pakistan. In the second grant, we wanted to go north to promote research around key national priorities, impact national policies, and then work with the WHO in the region. And what have we been able to do? We have this long-term training program, which initially had people come into Hopkins and do an MPH in the first cycle. In the second cycle, we started a master's program in the country, master's epi and bio, with a focus on injuries. And we started training people in country. And the current cycle, we have a PhD program, which is focused on emergency and trauma. Probably one of the few in the developing world. And we have the first candidate, who happens to be the first graduate of emergency medicine in the country. So we have clinicians who are getting into PhD programs through this program. 28 researchers trained, 26, 63 workshops, over 4,000 people trained in short courses. Also, 3 new PhDs, 3 to 4 master's theses in the current program, several funded research projects, multiple workshops and policy fora. Also, what for my own research interest is development of data systems and research tools. So we've been able to establish a road traffic injury surveillance system. There are over 500,000 patients registered in the system. Again, probably one of the larger ones in LMICs. And we have a trauma registry in some of these countries. So there's a data collection process that's going on, and a lot of people are working on it and publishing on things on this. Long-term training program. As I mentioned, 26 trainees. 2 of them are now associate professors, and several of them are not involved in many other interesting projects. In terms of outputs, and your slide, Nalini, does not capture all the publications, I think, which sort of started 2005 onwards. Over 100 publications, papers published by the program-supported personnel. And we recently published a BMC Emergency Medicine, a special issue on emergency and trauma care in LMICs. And finally, 2 NIS supplementary grants and joint proposals. So those are very, very interesting. But what I find most exciting is how institution gets impacted. So I think directly as a result of some of these things, we were able to establish the first academic department of emergency medicine in a medical school. So, all hospitals have emergency departments. But having a seat at the table with your pediatrics and surgery and medicine and being part of that group happened there in 2008 and was first in South Asia. That also resulted in first WHO collaborating center on emergency care anywhere in the world. So then started impacting the rest of the global policies, residency program, of course, and a master's in health policy and management, and a new MSc track in another city outside of AKU. And regionally, we had regional trauma registry system and a tool to assess trauma systems in multiple countries, including countries such as Iran, Iraq, Djibouti, Afghanistan. So a lot of that happened because of this grant. And finally, I think that allowed us to participate not just in emergency medicine discussion, but a larger public health discussion in the country and the region. So I want to thank you, Fogarty, and you, Nalini, for allowing us to do that, because I think though this relatively small amount of money is a huge impact in countries such as Pakistan, where now we have several programs in emergency medicine. There are multiple laws that were established primarily because of the work we were able to publish. And I think it's impacting lives much more than what we can measure. Thank you so much.